I'm Dan Polsky, by the way, professor at Johns Hopkins University. But the panel is realizing a new primary care vision. And really, our job here is to come up with some ideas that could, mechanisms for scaling a lot of the beautiful vision articulated in the first panel. They didn't hold back to try to make our job easy. But fortunately, we have a very distinguished panel here. As mentioned, the full bios are in your panels that you have. But to my left is Sherry Glied. She's the dean of NYU's Wagner Graduate School of Public Service. She's a premier health economist that really bridges research and policy over the past few years. Next to her is Emily Maxson. She's a partner at Despierta VC. She's a PCP and was previously the CMO at Adelaide. And next to her is Zirui Song, associate professor at Harvard Medical School, also PCP at Mass General Hospital, and really a leading thinker on payment reform. So we're blessed to have people that can actually solve the challenges that we have been given. So what I'd like to do is, well, I thought it was well articulated by Melinda, but my version of this nice vision articulated is we're going to have a joyous, trustworthy system with more money, well-functioning teams that triage patients to the right people at the right time, and helps everyone stay healthy and prevents serious illness. So that's what I heard.
Go for it.
But what I would like to do is, so let's just, I think before we just dig into it, maybe if each of you give you a moment to, what really stood out for you. We'll start with you, Sherry, from the first panel about this vision, just to kind of some initial reactions before we solve the problem.
So I was saying to someone that I suddenly felt very old, and Atul Grover pointed out that we had heard, we could have been sitting here 30 years ago and we would have heard exactly the same panel. And I think there's something interesting in that, right? 30 years ago, we would have been talking about how what we need is staff model integrated delivery with multi-specialty, multidisciplinary groups, nurse practitioners, well-organized delivery, the total patient, value-based purchasing, all of that stuff. And we thought it was going to happen because everyone was going to move into these staff model designs and it was going to be great. And a couple of things just to point out. One, it didn't happen. That organizational form did not triumph in the marketplace. It still exists. If anything, it's a little smaller than it was. We've done a lot to try and facilitate it, and it just has not happened. And I think we all should remember that it hasn't happened and think a little bit about why not. It has something to do, I think, with people's wanting certain kinds of choice in the marketplace, both physicians and patients. But within that context, I think there's two things to keep in mind also as we think about our vision. Back in that day, I actually wrote a paper about how do doctors behave when some of their patients are being paid using value-based methods and some of their patients are being paid in fee-for-service. And the answer is that's a really hard way to operate because you can't optimize the functioning of your practice for either modality of payment. You're sort of stuck in the middle. You can't decide whether you want to have more nurse practitioners. They'd be good for these patients, but not under this payment scheme. It's really hard to run that kind of mixed system. So I wrote another paper, which turned out to be completely wrong, saying for this reason, and because we see technology evolving that makes these kinds of integrated practices, makes there be a different way of wanting to organize a practice as an integrated practice than as a fee-for-service practice, I expect to see much more segregation of patients. Patients who are in value-based care will see one set of providers, and there'll be another set of primary care doctors who are being seen by people who are getting fee-for-service care. We haven't seen that. We've actually not seen, we still see doctors getting paid in 27 different ways by 27 different people at different levels, which makes absolutely no sense from an organizational perspective. And I think it's really interesting.
Thank you. What about you, Emily? You want to give some initial reactions to the first panel? What stands out for you?
Sure. So I really appreciated the thoughts of the first panel, and I will confess that I'm an eternal optimist. And I think this is possible with a lot of hard work and potentially a different administration. if I can say that. So why am I worried? I think that the comment on primary care and prevention having a PR crisis especially resonated with me, because trust undergirds all of healthcare. And if you can't take as a given that vaccines are a good thing that should be promulgated across populations however possible, and we should be empowering primary care to be a nidus of change, then all of these changes that are proposed, the vision is impossible, in my opinion, without empowering primary care. And I think that one particular challenge is that if we don't empower and encourage and raise up evidence-based leadership in healthcare policy, we regress. And we cannot achieve health outcomes that we desire. We cannot achieve efficiency with that type of regression. So I think we'll probably talk a whole lot in the coming minutes about some really important elements of regulation and licensing and payment. But I found that PR as an undergirding theme to be quite persuasive.
Sir?
Sherry, I remembered your paper back from grad school, Glied and Zibin, Journal of Health Economics.
That's it.
Right? I think a big distinction, building upon the Senator and Panel One's comments, between the US and other countries is that we largely live in a free market. The country is built atop an ethos and a structure fundamentally of a free market. And in healthcare, there are many market failures. Sometimes the market is lightly regulated. Sometimes it's largely unregulated. And you're beginning to see the lack of free market thoughtful regulation enter primary care in profound new ways. So we talked a lot about the workforce. Well, currently, not only do we have the retirement crisis of PCPs getting older, indeed PCPs are on average older than non-PCPs in this country, and we have the drying pipeline of students coming into primary care. Less than a third of residents in primary care tracks stay in primary care by their time of graduation. But those two longstanding facts are now joined by a third free market reality, which is that many primary care doctors, as noted earlier, are leaving for concierge and direct primary care, or DPC, practices, which have many benefits to the clinician and many benefits indeed for the patients who can afford them, but have a large spillover effect on the rest of society, and that the rest of society are now battling over fewer and fewer available slots. That free market reality is really connected to the underlying ethos of America fundamentally, and we haven't had a lot of policy or structural changes to really address that. It is one of my fears. In clinic, yesterday I was just in clinic, and we increasingly are concerned that our new residents and our colleagues across the years are leaving in the prime years of practice, but also closer to retirement, but with many years of good practice left for these newer free market models. And it's readily understandable why medical students choose not to go into primary care given the other opportunities. Indeed, there are big opportunity costs of choosing primary care. And until we change that balance, I think the free market will continue to rule. So payment is a mechanism, and I know we'll get to that later.
Well, why don't we start with payment? So at the break, we figured that we would really focus our attention to three broad mechanisms: payment, licensing, and other regulations. Maybe we'll start with payment, and we'll just kick it off with Zirui what would you propose we do with payment to achieve this vision? It's a simple question.
So respecting the time of my colleagues here, if we build on the Senator's comments about value-based care and this hybrid model, and what also our colleagues in panel one noted, I just want to walk you through a thought exercise of how we've tried to do this on the ground. The concept of value-based care or prospective payment with some kind of risk adjustment versus the practicality of building that on the ground are two incredibly different journeys. We talk often in policy discussions about the mechanism. We care about changing the mechanism from fee-for-service to something that's not fee-for-service. We focus less on the amount. It was noted by the Senator, and Toole noted this as well, the amount matters a lot. Incredibly central on the ground to the practicing clinician, to the person running the practice, is actually the amount per fee if you're in a fee-for-service world, or the amount per capitated life if you're in a per member per month capitation world. How do we get the amount right? I just want to show you, this is really revealing our vulnerabilities from my home institution, Massachusetts General Hospital, a journey going back a few years of walking away from fee-for-service primary care towards a per person per month value-based risk-adjusted primary care. I'll summarize very quickly as follows. Imagine all of us in this room are primary care doctors. Imagine in status quo, you've all got 2,000 patients, classic number for a full-time primary care doctor. Now imagine under 2,000 patients with fee-for-service, you're all of a sudden going to get moved out of fee-for-service to what we believe is this better world of this value-based payment. And again, I'm a champion of that movement as well. But how do we actually do it? The moment we flip from fee-for-service to non-fee-for-service, all of a sudden, none of us have 2,000 patients anymore. We have 2,000 opportunities to convey or reflect how sick our panel is. That's the immediate first step. So what that means is your organization or your payer or your state now has to assign a risk score to every patient you have. Step one of this journey is choosing the risk score. It is a highly financially consequential decision, incredibly murky for how to actually do that right. Now imagine that some of you have healthy patients, say the half of the room on the left. Some of you have sicker patients, say half of the room on the right. So you've got a healthier panel than average, and you've got a sicker panel than average. Your organization has to choose a risk-adjusted panel size target now, step two. It's got to pick a number. It can't pick the left number, it can't pick the right number. It tends to pick some number in the middle. Highly financially consequential decision. Do you use the median? Do you use the mean? Do you use some weighted average of the median or the mean? Do you just draw a number out of the hat? That's the target. The reason a target is necessary is that it's this flag stick in the ground for this is how productive we want our primary care doctors to be. The number of patients multiplied by the risk per patient has to meet this bar. You got to set this bar. I will say from our organization's experience, it's incredibly difficult to set that bar. Step three, now that you've set a bar, some of you practice in community health centers, some of you practice in the academic medical center on campus. You've got different types and populations of people with different risks. So now, per setting, you need a different bar. So now you got to split that one bar into many bars for the many settings your PCPs practice in. Highly financially consequential, incredibly difficult to do. Now, some of you have NPs and PAs in your practice, others perhaps not. Every NP and PA has got to count for some extra number of patients that are able to be seen. So you got to adjust that bar per PA, per NP. Getting that adjustment right, really financially consequential, really hard to do. Suppose we do all of this correct, and we're again in the same practice, one happy family together. Step four now is your organization sets a base salary. For meeting this flag stick in the ground, this bar for productivity, you get this salary. But of course, we live in a status quo where some of you have sicker patients. You've seen them a lot. You've gotten a lot of RVU fee-for-service revenue previously for them. You've been billing a lot. Others of you have been billing less. You've got healthier patients. Now we share this one bar, and what happens is if we move everybody to this bar overnight, you're getting a fee cut and a payment cut. You're getting a salary increase. You'd be thrilled on this half of the room. You'd be not so thrilled on this half of the room. So what's step five? It's a transition period of really thought. This is really leadership management 101, selling the model, enculturating the model within the practices, within your colleagues, speaking about the merits, doing the town halls, doing the meetings, getting everybody on the same page. But what does it ultimately mean financially on the ground? For those of you who have been underpaid relative to this model, you probably don't want to stay underpaid relative to the model, so we're going to subsidize you. We're going to raise your income directly to that level. That costs money. It's a great thing, makes people happy, that costs money. For those of you who've been billing a lot more than this bar in the ground, can we take away some of your salary to get you to we can't do that. That's not a very easy thing to do on the ground. So we're going to subsidize you for a set number of years to stay at your historical salary. That costs money too. On both sides, it costs money. Turns out at the end of the day, to do this really well is very hard. And I think I would resonate with the senator, with our colleagues who have long championed moving from fee-for-service to prospective payment because it does all of those wonderful things with the air conditioners and everything else that we have heard. I just want to plant this sort of reality on the ground that to do it for primary care and to do it well for practices is exceedingly difficult. And I would venture that we don't have a best practice or playbook for doing this. My own home institution, Dan's former colleague, Josh Metley, my chief of medicine, the sweat equity put into doing this with our finance colleagues over many years. We've learned a lot of lessons. We've had a lot of stumbles. We have a lot to share. But for the country to do this across all the health systems and the community centers and the practices that are private practice, it's a tall order. We're very far from that vision based on where we are today. Not to say we shouldn't do it.
If I can add just one, I think that was beautifully stated. I think that for the patients across the country who have their care in private practice, what we've seen at Aledade, which built ultimately the largest network of independent primary care doctors in the country, what we saw is that it was really different to motivate physicians who owned their practices and who sought to reap the rewards of their hard work and their transformation, and the employed physicians, where you really do have a disparity and they're not necessarily seeing the fruits of their labor because maybe the incentive structure isn't there individually. So totally echo that it's extremely challenging. Another challenge is that it's very different from setting to setting, and we need to acknowledge that we're going to need structures that motivate folks who are used to calling the shots and earning in a commensurate way with the effort they put forward, and those who don't call the shots and are subject to salary increases and decreases, as Zirui has described.
Sherry, would you like to chime in on this one?
So I think one of the really interesting things is that if you look across the OECD, the main way doctors are paid is fee-for-service. There's very little non-fee-for-service. There's very little value-based payment in other countries. They also don't do social determinants of health in physician practice. Many of the things that we think must be the reason that we do so much worse than those other countries simply do not obtain. They have shorter visits. There's lots of stuff that we do. We think about how this all ought to change, that there is no model that we are following. It's very much a vision without a concrete reality that we're tying it to. One of the things that I kind of hope with AI and electronic health records and so on is that there will be more research looking at the guts of what's actually happening in primary care practices. How many minutes are doctors spending doing different things? How does that vary with the way they are paid? Because I think we believe fundamentally that when you make a change like you made, something real happens on the ground. The way patients are treated changes in ways that are big enough to make that whole effort worthwhile. But our evidence on that is pretty limited and is usually, because of the way we do our analysis, very marginal. What we'd like to see is that the investments down the road are different. The way we set up the practices is different because we've changed the way we pay. And back in the day, there used to be more studies comparing like what happens at Kaiser compared to what happens elsewhere. We need more of those studies.
So before we leave the chapter of payment, just to kind of see if we have some consensus here. So what I hear is let's not abandon value-based care, but if we're going to move in that direction, we really have to be committed to the hard work of change that it involves and look at it in a more sober way instead of the way it's kind of presented in a one-on-one class. We pay for doing stuff. We don't pay for like getting outcomes. We should be paying for health. It just sounds so monolithically great, but in practice it can be quite challenging. But I also hear some pushback is that maybe we should be also sober and looking at our fee-for-service system and seeing potentially on the ground is anything actually changing? We have to really look at the outcomes a little more closely. If we are going to move to value and do that hard work, we're really going to need to see the outcomes or the changes in the way primary care actually practices. That's my summary.
Let me just add one thing. Like, value-based care assumes that you pay by outcome, But we have never really done a great job of measuring those outcomes. We might think that we could just pay fee-for-service, measure and display the outcomes, and let patients go where they will, right? Why do we have to, that's how we do most things. It's not necessary that we tie those things together in this mechanical way. But we're really not that great at measuring outcomes, so I don't know.
Emily, you want to chime in?
I was just going to add that fee-for-service primary care revenue is not the problem. And if you look at the proportion of healthcare spend that is spent on primary care services, it's piteously low compared to specialty spend and imaging spend and laboratory spend and duplicative testing, right? All of the, crossing the quality chasm, and to error is human, et cetera. We are doing a better job at aligning incentives in primary care than we are in the specialty space because the pain points are different. Right? They are commanding great salaries when they enter into subspecialty fellowships, and right away they graduate and they have a patient panel, they are in demand, they are able to bill at a high rate, there are very little regulations or bounds around their spend, right? And so it's harder to convince them that they should jump on this very difficult bandwagon and that they too should have a foot in each of two canoes, which as we've discussed is quite challenging. So I think that payment reform is a really positive thing. Completely agree that we should be paying primary care doctors more and putting more money into that healthcare system. And I think that until we address the reimbursement disparity and specialties and the fact that you can overspend in specialty care without getting desirable results for your patients, I would like to see more payment reform efforts in that category as well.
So I'm going to pivot a little bit. We could have a whole panel on just payment, but I want to at least cover one other and talk about licensing because so much of what we talked about in the previous panel was on the role of teams, and so many different professionals can work together to achieve a primary care system that we would like for our future, and I think licensing is a key mechanism to get us there. But before we jump into that, we're going to try to save some time for questions. So please write your questions down, or actually what I think we'd like more is people to solve the problems for us and just write them on those little index cards and pass them up to the front. Who wants to start with the just general bucket of licensing and how we move towards teams? Maybe, Emily, we could start with you.
Sure. When thinking about this particular category, I'm thinking about the comment that we need more standardization in licensing, which makes sense to me. But I also want to think about the comment that AI could be well integrated as a team member in the primary care office. And if I think about primary care advancements in not just the United States, but also in low and middle income countries, there's a use of this healthcare workforce and community health workers where you're solving for the trust divide right away by getting people who are well known to the community, but they are unlicensed and extremely valuable, potentially. So how could we use AI not just to work on the efficiencies, but to help unlicensed individuals in the community to deliver high quality protocol-based, evidence-based care and have AI really support that population to be an even better member of the primary care team? I think that that's really interesting and something that we should be exploring. We have the workforce, it's a trusted workforce. How do we make sure they're delivering the best complementary care possible?
Sherry, would you like to go next?
So I'm going to go in a different direction. I want to talk about standardization for a second. There's lots of dispute about whether we need licensed or non-licensed people, so I think that's a separate question. But I think if you're going to have licenses, they should be standardized. There is no sense, really, in having a system of licensure in which you can't be sure what it is exactly people do, and it makes it really hard. Just to beat a dead horse here, I'm really interested in the organization of care and how we put teams and AI and all the other things, components together. That can't really happen unless we know what the components mean. If different people called the same thing can do different things, it becomes really impossible to build something. I'm struck by the fact that I was just talking to somebody about this yesterday. The New York City subway system was built by 3 independent private companies. The gauge on the train tracks is different for the 3, which means that even now, 100 years later, you need to buy 3 different sets of train cars. You can't move things around when things go wrong. This is not how you want to build an organization. Having standards is a function of government, trusted advisors to government. We should have standards. Absolutely, I think that's an easy one.
Zirui, you want to join the conversation here?
Sure, just very briefly, by nature, primary care has to handle anything that comes through the door, which makes licensing a really interesting intellectual exercise. What are you licensing for? If it's for a procedure that you're doing thousands of times over the course of a year or career, there are certain metrics and just the volume outcome relationship we know from procedural specialties that govern a lot of licensure. But primary care is almost analogous to being a cashier at a grocery store. Like when I was in high school, I was a cashier at my local grocery store. Anything that comes down the lane, you've got to scan it or figure out a way to scan it. If there's nothing to scan, you've got to type in the 4-digit code and measure the weight and get it to register on the thing. And the fundamental, I think, clinical fascination that that really intrigued me about primary care and many of my colleagues in the field is somebody walking in with abdominal pain could have anything ranging from they ate something bad last night to stomach cancer. And it could just be anything in the middle. The licensure for that is really a thought process and approach. Like the expertise is a approach and a thought process. And of course, some of the expertise is the human being. It's the relationship, like Ileana talked about. It's the trust, which is essential. But it's very different from procedural-oriented care, which also influences how you think about offloading some of the primary care responsibilities to allies and others and colleagues. It's the approach, or part of the approach, that you're offloading. It's different than offloading a task. Somebody with a headache could be anything from anxiety to brain cancer, and anything in the middle. So the nature of primary care makes licensing, I just think, altogether a different thought experiment, and also influences how we think about the construction of teams.
And in some ways, your answer loops us back to value-based care, in that if it's difficult to define each job and what that fee-for-service delivery is for each piece of the primary care visit or set of visits in a day, it moves us more towards value-based care. So I'm going to segue into my first question here. We've been talking about value-based care under kind of models that have been implemented under the past 10 or 20 years. So the question is, what new value-based care models might help us realize this vision? And there's a follow-up to that. Can we test paying PC more, primary care more? Of course, more is always better. Does someone want to take this question on potential new models? Maybe Emily's been out in the field on implementing models the most. Maybe you have some thoughts on that.
Sure. So I think part of the problem in the implementation of accountable care models and VBC models historically was that it took quite a long time to reconcile the work that you put in and to receive payment for shared savings. So you could have a year of performance in MSSP, and you don't get that payout until September of the preceding year. And you've needed to take a leap of faith and make an investment in analytics, patient outreach, all kinds of population health functions in order to get there. And that was highly impractical. So some more prospective payment models were released, ACO REACH, et cetera. And I think all of these are sort of encouraging a gradual shift toward capitation and taking the true and consummate total risk of cost of care for a patient population. And I think that these are great movements. As I mentioned, these put the onus on the primary care doctor, and the primary care doctors of this country, I think, are doing a pretty fantastic job of trying to figure things out as they go. Where do we see total cost of care fail to come down? What is the white whale and the holy grail? It's specialty cost. Once again, the cost of oncologics. What are you going to do about that? We need patients to have access to the topmost research. So if I allow myself down that rabbit hole, I start thinking about how quickly we were able to develop COVID vaccination and how maybe with some reform we could do things more efficiently and get novel delivery out there instead of perpetuating this sort of high cost of research and new therapeutics. But that's a long road, that's a very deep rabbit hole and probably not productive, right? So one thing that I think has challenged me for my entire career thinking about value-based modeling is how do we incentivize highly paid, very well taken care of individuals in a different way when they have very few pain points. And some people will say, well, they're seeing more than they need to see. Their offices are encumbered by lots of cases that don't need their particular level of training. And I think that that's something that we could work on. But at the end of the day, their salaries are high, more people are going to surgery than might need to, and there are other evidence-based ways to practice. This is complicated by the rise in longevity medicine, right, which is essentially perpetuating grade D USPSTF recommendations for people who are willing to pay for them, and I think that's terrifying. Because guess who's going to hold the bill when after that full body MRI scan, you go and you chase the biopsy that wasn't needed and your lung is punctured and you go to the emergency room, right? Like your insurance or the healthcare system is left holding that bill. So I'm obviously a big proponent of evidence-based medicine. I think we need more research on how to change this. I think one big thing in the literature that we haven't yet talked about is that a lot of costs incurred by Americans in the healthcare system are probably better taken care of as social determinants of health, and they are all upstream that lead to downstream expenditure. And how do we take care of that? Well, today there are some payment models for screening of SDOH. What are you going to do? You screen your patient population, you find out that there's housing insecurity, what are you going to do about it? It's incredibly demoralizing as a PCP to find out that you have this need that you just can't care for. And as Sherry has said, other countries aren't expecting their primary care doctors to solve housing insecurity and food insecurity. And that is a problem. So I think we need adjacent policy support and payment mechanisms to primary care. As was mentioned in the first panel, how are we going to build the social structure? How are we going to pay for what people actually need adjacent to primary care? Well, we need to know what works for social determinants of health. And I don't think we have evidence-based strategies in that domain as we have for population-level screenings and intervention. So I'm a big proponent of practical evidence-based research and hope that we can see funding resume someday soon so that we have practical opportunities and interventions for our patients. So I'm not trying to get away from the real question, which is what are some value-based care models? I'm just trying to point out value-based care models can take care of spend to an end, and then we need more help. And how do we do that? We have to marry value-based care models, the shift to capitation, the responsibility and accountability for total cost of care with social structure, the PR campaign, et cetera, so that we can make more holistic gains.
We are heading towards the end here. Emily just put a lot on the table there, but I think, just to lift up, the primary care system is complex as it is, but it really interacts with the complexity of the entire healthcare system, the entire social system, and we can't just solve the primary care system in isolation. I think that was just really well laid out for us. That'll be our next panel, but we just have a couple more minutes. So. We started with this charge, realizing the primary care vision. So very quickly, Zirui, we'll start with you. What would be, the one thing, the highest priority thing we should lean on next to really realize a new primary care vision?
Changing the allocation of RVUs in the fee schedule would be really helpful. The roots of a lot of this is in the late 80s fee schedule, where the classic, your most billed code in America, the classic 15, 20-minute office visit with your primary care doctor is worth 1 relative value unit. If you spend that 15 minutes taking out somebody's cataract, that's 10 relative value units. essentially a 10-to-1 ratio in how you spend your time as a future physician. That is really at the root of all of this. And when you calculate capitated payments, it starts from a fee-for-service infrastructure. You're multiplying that up, of course, adjusted by the risk score. But it all starts with the underlying RVU allocation towards what we think are primary care services or work. And my other quick addendum is I think looking to the states is really helpful. The senator mentioned a lot about Rhode Island this morning, obviously, and Rhode Island is a leader in state investments in primary care. The OHIC, the office he noted, was one of the first in the country to essentially require increases in primary care spending as a share of total, starting out with commercial insurers. And in 2007, before they did that, Rhode Island spent $48 million total on primary care that year, $3 million of which was non-fee-for-service dollars. So 3 out of 48 million. By 2023, a decade or so after this policy, Rhode Island spent $86 million on primary care. And guess what share of that, or how much of that was on non-fee-for-service payments? 52 million. 52 million out of 86 million was now for non-fee-for-service payments. So they've actually done it. And a lot of our colleagues are looking to study the impact of that on continuity, care delivery, volume, as well as prices, and also the outcomes and patient satisfaction. So there's a lot to be learned. And because of Rhode Island's example, other states like Colorado, Oregon, Delaware, to some extent, Virginia, Pennsylvania, Maine has talked about this. Massachusetts is trying to do this. California did, if I didn't mention, passed the law. So many states have taken this lead to try to essentially legislate this increase in primary care spending. And now the question is, what do you do with that analogously $52 million of non-fee-for-service spend? Going back to our initial little journey of stumbles from home, my last question to the audience, if you imagine we did the thing we talked about earlier of the 5-step process to get out of fee-for-service, what is your guess for what happened in year 1 on average amongst the primary care doctor? So on average among us in the room, if I ask you, you no longer have a fee-for-service incentive. It's no longer bill as you go. You've got your capitation, you've got your salary, risk adjusted. Imagine we made all the right decisions in that 5-step process. Any guesses for what happened to, let's say, volume of visits in primary care in the first year?
Wait.
Show of hands for it went up. You saw more patients, saw them more frequently. Show of hands for it went down. You saw fewer patients, saw them less frequently. Yeah, volume dropped by about 10%. Primary care lost $10 million in the first year. And that led to a real reckoning, or re-reckoning, or the appropriate version of reckoning, for what to do with this. And so believe it or not, as part of the solution for correcting that loss, because we're still being paid fee-for-service by a lot of our payers, even underneath value-based contracts, we re-implemented a fee-for-service incentive. The next year, we went back and we said, if your colleague is on vacation or sick, by seeing one of their patients in clinic, you get a fee-for-service fee. Because when that fee-for-service fee wasn't there anymore, and your colleague is out on vacation,
You took vacation.
turns out we don't see our colleagues' patients as much, and that's actually like a bad thing. We re-implemented fee-for-service back into capitation. I just thought that was such a sobering lesson for human behavior, as Sherry can teach us from basic economics, to really the practicalities of how you do this.
And I didn't even ask you what happened to coding, but I'm going to bet.
Yeah, the crux of the story for the coding part is some of you in the room code really well. You know which codes are payable, which codes are not. Others of you have not had exposure to that, so you're coding what you're seeing. And who do you think really suffers financially in this capitation payment model? Those among you with healthy patients on paper. Healthy appearing patients on paper are really disadvantaged panels in the payment perspective under capitation. So we've all got to now learn how to code. Is that really where we want primary care to go? Again, I'm not saying we shouldn't do this. In fact, for 10 years we studied the alternative quality contract in Massachusetts, which is a value-based payment ACO type model. I really do think it's a move in the right direction. It's just that when you apply it to primary care, you have to solve all of these subsequent issues to get it right.
Sherry, would you like to share to the room? We have a couple more minutes. What you would lift up. We're given 5 minutes. We have an extension. I hope that's okay with all of you. This is, but we're going to try to come up with a high priority item that we should leave this room
So
and
I
go
am
do.
struck by the fact that we haven't done enough recent research on what primary care actually is today, how these different payment mechanisms are rolling out today, with the knowledge that we now have, which we didn't really think about. We didn't think about coding in the 90s. We didn't realize that coding was going to be the game changer. So with our understanding of coding, with much better data, with electronic health records. So let me just, I was thinking about it on the flight here about primary care. What is primary care and how it has changed so much over time. Now, I live in an incredibly dense part of Manhattan with lots of people. So there are urgent care clinics and there are lots of primary care doctors and lots of specialists and everything. When I use those different services, as does my husband who has lots of chronic conditions, in a whole bunch of ways. He goes to the urgent care, he goes to his primary care doctor, he goes to his specialists who all share an electronic health record. So his primary care doctor does not need to be the captain of the team because all of the specialists actually know what the others are doing, which would not have been true 30 years ago. The Minute Clinic down the street would not have been there. The telemedicine visit he makes when he doesn't feel great wasn't there. We need new research. We need to understand what this animal is. We should stop thinking that it is what it was 30 years ago, and we should stop being nostalgic. Nostalgic is a terrible way to do policy or anything else. So that's my...
And purposely, we're going to end with the eternal optimist here, Emily, to give us some priorities for moving forward.
I think we need a just-in-time intervention to reinforce the importance of evidence-based prevention and primary care in the eyes of patients and policymakers. I think it's a very dangerous time right now, and I think the trust erosion,
I said the
as
optimist.
I mentioned, well, I'm getting there. I'm getting there. I promise. Some things there's not being any optimist about, but I do think that if you look at the employer-sponsored healthcare space, they're spending a ton of money on benefits for their employees. And what we see is that their employees are not leveraging those benefits. They're not getting their preventive screenings. They're not necessarily even getting their vaccinations at the same rates as they used to. And so employers are seeing more downstream spend, right? They've gone through the river and they've fallen off the waterfall, right? And that's where the costs are incurred because now they have a cancer that was caught at a later stage than it would have been had they done their mammography or their colonoscopy screening. And so why is this? We talked about trust, we talked about access and how it's difficult to access care when you need it, where you need it. And I think we have to address those factors. And if we have public policy discouraging the very things we as primary care doctors are seeking to promote, we're at cross ends. And so I really think we need to make sure that we uphold individuals who can message health and prevention and wellness, and those are our nation's PCPs. And if we can empower them, give them the megaphone, so to speak, and help patients regain that trust in these experts who have trained for a long time to serve them, we will be better served as a healthcare system.
Well, with that optimistic note, thank you, Emily. I would like us all to join me in thanking our tremendous panelists on a really great session. And a couple other thank yous. I'd like to thank the Center for Health Systems Policy Modeling and Melinda Bunton for organizing this tremendous event, and Lauren and the entire team for doing such a great job in putting this all together. So a thank you to them. And finally, the most important thing is there's a reception in the back. So please join us and share some thoughts. And if you have any other comments, we're going to try to write some of this up. So please share your thoughts, because finally, I guess it's to thank this tremendous audience. Many of you are experts in this area, and we value your input on these issues as well. So thank you to the audience. Enjoy the reception in the back.